Hello again, and welcome back to the second episode of APHA's 15 on COVID-19 series. Today, we're going to be taking a look at an overview of COVID-19 disease. In case you missed yesterday's episode, we really took a deep dive into antimalarials for the treatment of COVID-19. Today, we're going to take it back a level and just give a broad, high-level overview of COVID-19. So thank you for joining us. Once again, my name is Dan Zlott. I'm the Vice President of Education here at APHA. Prior to joining APHA, I spent 10 years working at the National Institutes of Health as a clinical pharmacy specialist in immunotherapy, oncology, and immunology. Let's go ahead and dive right in. I have nothing to disclose. Today's learning objectives. At the end of the activity, you should be able to discuss the latest developments related to COVID-19. So again, a brief review for those of you who missed yesterday's episode. What is the 15 on 19 series? It's a regular education series that's designed to provide general education about various aspects of the COVID-19 disease. There's just so much information being put out there, and it's being put out there so quickly that it's difficult to keep up. It's also difficult to separate fact from rumor, from hypothesis, and so that's the main goal of the series, is to help you sort through all the information that's coming your way to help you keep it straight, and so that you can give the best information possible to yourself, to your colleagues, and to your patients. And of course, it also provides 15 minutes of CE for pharmacists and pharmacy technicians. So as discussed yesterday, we've got some ground rules for the series. Each episode will be 15 to 20 minutes in length to help you get up to speed quickly. We're going to cover one topic in each episode. Again, today's sort of a potpourri, just a general overview. And we'll attempt to clearly state whether each idea or concept is fact, hypothesis, or rumor or fiction, again, to help assist you in evaluating all the information that's being thrown at you. It goes without saying, again, as I said yesterday, information on COVID-19 is changing daily. So what's true today may not be true tomorrow. Things that we're looking at today in terms of hypotheses may turn out to be fact tomorrow. And a lot of things that are rumor or fiction will probably still be rumor or fiction tomorrow. But again, we're going to keep taking a look at it until we figure it out one way or the other. All that being said, it is your responsibility to stay informed. We will do our best to go back and update information that becomes outdated, but because of how quickly things are changing, we can't guarantee the accuracy of information past the date that we originally presented. Information in these presentations is, of course, the opinion of the speaker only, and they don't necessarily reflect the opinions or guidance of the American Pharmacist Association. Our lawyers are satisfied now. So with that, let's go ahead and dive into today's 15 on 19 series. So let's just start off in general. What is COVID-19? COVID-19 is the name of a disease caused by a new or novel, well, we've heard that a lot, right? Novel coronavirus. It just means that it's new. We haven't seen it before. So it's a new strain of coronavirus called Severe Acute Respiratory Syndrome Coronavirus 2, or SARS-CoV-2 or SARS Coronavirus 2. The COVID-19 acronym is derived from the official, I use the word official loosely. There's a lot of different names out there, but WHO and CDC have settled on Coronavirus Disease 2019, and so you can see where the acronym comes from there on the slide. So in case you've been wondering how we get coronavirus and COVID-19, there you go. And just for the sake of simplicity, it gets really confusing to go back and forth between the name of the disease, which is COVID-19, and the name of the virus, which is Severe Acute Respiratory Syndrome Coronavirus 2, or SARS-CoV-2, or SARS Coronavirus 2, take your pick. It's just easier to refer to COVID-19 or the COVID-19 virus when referring to the disease or the virus, respectively. And in case you're interested, the image on the slide is actually a scanning electron micrograph of the COVID-19 virus. So what exactly are coronaviruses? We've heard a lot about them as of late, and they've come up before in the past, and we'll talk about that in just a second. It turns out that coronaviruses are a group of viruses that cause a whole range of diseases in birds and mammals, including chickens, ducks, cows, pigs, and of course humans. And the diseases actually have a pretty broad range of symptoms. They can be gastrointestinal in nature. They can be respiratory in nature, as is the case for SARS, for COVID-19. So there's a pretty broad range of tissues and organ systems that can be affected by coronaviruses, depending on the particular coronavirus. Coronaviruses are an interesting group of viruses. They're enveloped RNA viruses, which contain an unusually large genome. So they have a lot of genetic material, and they're characterized by a club-like spike protein on the virion surface. And the image here is actually a model of the COVID-19 protein spike, and we think that the COVID-19 protein spike is what interacts with the ACE2 molecule on cell surfaces and allows the virus to gain entry into the cells. So when we talk about enveloped RNA viruses, what does that mean? Well, some viruses are just encapsulated. They just sort of have a small capsule around their genetic material, while others actually, as they're leaving the host cell, they borrow a bit of the cell membrane, or in the case of coronaviruses, it's actually the membrane of the Golgi complex as they're budding out of the Golgi complex, and they wrap themselves in that cell membrane, and they trick the cell into inserting various viral proteins like these protein spikes into the envelope that goes around them. And so that's what we mean by an enveloped virus. I mentioned earlier that we've encountered coronaviruses before, and in the case of SARS and MERS, so SARS was the original severe acute respiratory syndrome, that was first encountered in 2002 or 2003, depending again on which piece of literature you read. And then, of course, more recently in 2015, 2016, if memory serves, we started to encounter the Middle East respiratory syndrome, or MERS. And again, both of those were caused by coronaviruses. So this isn't our first encounter with something approaching a pandemic caused by coronaviruses. All right, well, now that we've got an overview of coronaviruses and what they are, let's talk specifically about COVID-19. And let's start off with the symptoms. So we've heard a lot about the different symptoms that patients present with when they are infected with COVID-19. And so let's talk about this. This information is largely based on data coming out of China, and it represents information about patients who present to the hospital. So this is a little bit different than general patients out there. These are patients who actually got sick enough that they went to the hospital, and so take that for what it's worth. But here are the various symptoms that those patients encountered. The first was cough at around 67-68% of patients, and almost half the patients who had cough seemed to have a productive cough, and so that incidence there was 33.7%. The next most frequent symptom was fever, and that was present in almost 44% of patients. Interestingly enough, in that same paper, over the course of the disease, I believe they said up to 88% of patients ended up experiencing fever at some point during their hospitalization. So that seems to be a hallmark of COVID-19 disease. Almost 40% of patients presented with fatigue. Just under 20% of patients presented with shortness of breath. About 15% of patients presented with myalgias or arthralgias. So if you look at this again, there's a lot of similarities between flu and COVID-19, which sometimes can make diagnosis challenging. And in fact, as we talk about testing, which will be an episode in the future, it's really challenging sometimes to distinguish the clinical features of COVID-19 from flu just based on symptomatology alone. Approximately 14% of patients presented with sore throat. Just over 13% of patients presented with headache, and about 11-12% of patients presented with chills. So there's, again, your symptomatology at presentation to the hospital. So the next question that comes up is, what's the clinical course of COVID-19? How does this progress over time? And so let's start off with a group of people who actually don't have any symptoms at all. So it turns out that a significant proportion of those who are infected with COVID-19 experience no symptoms. And we're still looking at what exactly this proportion of the population is, but it ranges from 18% to as high as almost 60%, depending on which study you look at. The 18% figure came from a study of the folks who were trapped on the Princess Cruise Line in China off the coast of Japan for a while. They actually were swabbing people there for surveillance, and they found about 18% of the population ended up testing positive for COVID-19, but they never had any symptoms. Another study coming out of China estimated that as high as 60% of patients have no symptoms whatsoever. Couple things with that. This particular article has not undergone peer review yet, so I'll just throw that out there as for what it's worth. What's interesting about that also is the model that they used in terms of basically assuming exposure, basically said that everybody had an equal chance to infect others and spread the virus, if you will. And it turns out that model may not be entirely accurate. If you think about it, we all spend time with certain individuals, and we're far closer to certain individuals than to others. So the idea that we all spend equal time with each other and have an equal chance to spread the virus to others, I'm not entirely sure that's relevant. That's not exactly my area of specialty, and so take that for a grain of salt as well. The truth is probably somewhere between 18 and 60% is the reality in terms of how many patients are actually able to be infected without having any symptoms whatsoever. Now, according to a pretty large experience coming out of the Chinese CDC, about 81% of COVID patients experience mild symptoms. So they have symptoms, but they're extremely mild. And so the interesting thing about that is that it's not entirely clear how many of those patients presented to hospitals versus how many presented to other clinics. That level of information wasn't available in the report. So I suspect over time this number will be refined as well. So now let's start talking about patients who have moderate to severe symptoms, people who actually do go to the hospital. It turns out that patients with moderate to severe symptoms present to the hospital approximately 4 days after symptom onset. There's a little bit of a range in the literature. It's usually 4 to 5 days, though, seems to be about the average. So from the time you start exhibiting symptoms to the time you feel sick enough that you think it's time to go to the hospital, that's about 4 to 5 days for patients who get to that point. Clinical deterioration to the point where maybe you need to be transferred to an ICU appears to occur an average of 8 to 9 days after symptom onset. And so there's a couple different studies coming out that are both coming out of China that look at this differently. Approximately 9% of patients were admitted to the ICU an average of 8.5 days after symptom onset in this one study. And in a second study, this other study reported that 30% of patients were admitted to the ICU 10.5 days after symptom onset. Now, up till now, pretty much everything I have told you is fact, with the exception of anything that I said I was speculating on. This is another point that I'm going to speculate on, and this is my speculation. This is not backed up by data, so consider this my hypothesis. What's interesting about these two figures is that the first figure comes from an experience much later on in the Chinese coronavirus experience. This was published in March, whereas the second figure, the one about 30% of patients being admitted to the ICU, was published earlier on in February. And so they're using data from the very beginning of the coronavirus outbreak. So I suspect that what's happening is that people are gaining experience in how to manage coronavirus, and that's why you see some differences there in terms of how frequently people were transferred and how quickly people were transferred. So again, that's just my theory. That's not confirmed in any literature other than my thoughts. About 3% of patients develop acute respiratory distress syndrome 5 days after symptom onset. So these are the folks who go from, fine to not fine in a hurry, and they develop full-blown ARDS, and they land in the ICU. Approximately 86% of patients were discharged with an average length of stay of 16 days. So the vast majority of people recover, and the average length of stay is just over 2 weeks. And again, this is all based on the Chinese experience. So the next question that keeps coming up is, what is the mortality rate for patients with COVID-19? The overall mortality rate in China is reported to be between 0.8 and 2.3%. Again, the 0.8 comes from experience much later on, whereas the 2.3% encompasses sort of China's experience from the very beginning. And so again, this is me speculating. I suspect that over time they have learned how to manage this more effectively and more efficiently, and that may be why we're seeing lower mortality rates coming out of some of the later studies as compared to some of the earlier studies. So again, just to make it clear, that is speculation on my part. So what is the cause of death for patients with COVID-19? This is something we've been hearing a lot about. At present, the published autopsy data is pretty limited, but I was able to find one very complete autopsy report from a single patient. And so in the lungs, what we find are diffuse alveolar damage, and that's what you expect in a respiratory disease. Findings consistent with acute respiratory distress syndrome, so evidence of pulmonary edema. One of the other classic hallmark findings of ARDS is hyaline membrane formation upon microscopy after the specimens have all been processed, and so they found that in this individual. They found significant inflammatory changes. So they found interstitial mononuclear inflammatory infiltrates, and essentially that's another word for T cells. There's probably others, but mostly that's going to be T cells. In addition, they found some changes consistent with viral infection. So they found some unusual cytopathologic findings in the lung cells, unusual nuclear shapes within the nucleus of the cells, etc. So in the liver, they found mild damage of unknown cause. The authors in the article speculated that it was either drug-related or potentially related to COVID-19. The heart, there was no obvious damage, but they did find a few interstitial mononuclear inflammatory infiltrates. So again, some T cells were present, but they weren't there, tearing down the house or anything, but they were present, which is interesting. In the blood, now this is where things I think get really interesting. I come from an immunology background, so I'm a nerd about these things. Take this with a grain of salt. But the fact that there were highly activated CD8 T cells with high concentrations of cytotoxic granules, essentially this is consistent with a very potent immune response, and it's also consistent with the immune injury that the pathologist found in this particular patient's lungs. So it just helps to reinforce the idea that a lot of the damage or a lot of the symptoms from this disease are not caused by the virus itself, but instead are caused by the immune reaction, the immune system's response to the virus, and what that does to some of the tissues, particularly in our lungs. So let's move on now to the transmission of COVID-19. This is another area that's been rapidly evolving. Viral load and presumably viral shedding. Now, the two are not necessarily related, but so that's a little bit of an assumption. But definitely viral load appears to peak within 2 days of symptom onset. This is unusual. When we look at SARS, the prior coronavirus outbreak in the early 2000s, the viral load didn't peak until much later on in the illness. And we think that this is one of the things that makes COVID-19 so transmissible. You're able to spread it really before you know you're sick or before you know you're seriously sick. And so that's one of the factors that they think is responsible for how rapidly COVID-19 has been spreading. So again, a little bit of speculation there, a little bit of hypothesis. But the definite fact is that the viral load peaks around day 2 of symptom onset. The average duration of detectable viral RNA in infected patients is approximately 20 days. But it's unclear if you actually shed virus for 20 days. Just because there's detectable viral RNA doesn't necessarily mean that there's intact virion particles that are able to go out and infect other people. So that's still an area of active research. So how exactly does this spread? Well, we're getting better data that transmission may occur through respiratory aerosolization of the virus. So this work is based on some interesting research that was done at the National Institute of Allergy and Infectious Diseases Rocky Mountain Laboratories. So very recent data suggests that once the virus is suspended in a fine particulate, the virus can remain viable for more than 3 hours in confined spaces, and that's suspended in the air. So that's interesting, a little bit scary. It just confirms that this is maybe a little bit more easily spread than we originally thought. Transmission also likely occurs via contaminated surfaces. So this same group looked at how long the virus is able to survive on various surfaces, and they found that in steel and plastic, the virus is able to survive for up to 3 days. On cardboard, the virus is able to survive for up to 24 hours. Another area that we've been getting a lot of questions about are the risk factors for COVID-19 mortality. So let's dive in and take a quick look. So in one study where they looked at hospitalized patients and attempted to identify risk factors that were statistically significant, there were 3 risk factors identified, and so those 3 were older age. Now this study didn't actually quantify what older age is. It didn't say more than 65 or more than 80. It just said older age. So it's a little bit fuzzy. The next one was a higher SOFA score, sequential organ failure assessment score. So if you're familiar with critical care medicine at all, you're pretty familiar with the SOFA score in terms of performing quick assessments on risk for your patients. It applies here. And then lastly, if you had an elevated D-dimer at greater than 1 microgram per liter. So these 3 risk factors are also somewhat similar to risk factors for severe pneumonias. So a little bit of overlap there between the 2 conditions. Now, when you look at the entire population, not just the hospitalized population, these numbers come from the Chinese CDC, and they did an analysis of over 70,000 cases. So quite a lot of data here. The risk factors that they came up with, the number 1 risk factor was age greater than 80. And then they listed comorbidities, and the comorbidities are listed in terms of basically descending order. So the first one will be the highest risk and the last one will be the lowest risk. And so the comorbidities that they identified as resulting in an increased risk were cardiovascular disease, next was diabetes, then chronic respiratory disease, hypertension, and finally cancer. So there's your risk factors, and that will wrap up today's 15 on COVID-19 presentation. Thank you very much for your kind attention. Just like yesterday, we want to hear from you. Are there questions that you'd like to have answered? Our goal is to help you educate yourself, your colleagues, and your patients about COVID-19. So if you have suggestions about topics you'd like us to cover in future episodes, please email them to covided@aphanet.org. Again, that's covided@aphanet.org. Do please keep in mind this is an inbound only email address. We won't be replying to messages there. And for our next episode, we will be talking about NSAIDs in COVID-19. And we're hoping to release that on Friday, Friday, March 27th, time allowing. So we hope you'll tune in on Friday to learn a little bit more about COVID-19.